Good morning, everyone, and thank you for being here today. I'm Dr. Asim Hassin, and I'm pleased to welcome you to this session on endocrine and metabolic emergencies. Today, we'll be focusing on a critical topic, severe hypoglycemia. We'll cover what it is, how to recognize it, and the best approaches to manage it effectively. I look forward to sharing insights that can help you better understand and handle this emergency situation. Let's get started. Now, let's look at this scenario. A 67-year-old diabetic on insulin is found unresponsive, and the capillary glucose test is unreadable because it's too low. The key here is recognizing that this patient is experiencing hypoglycemia, which can be life-threatening if not treated promptly. In such cases, our immediate priority is to raise the blood glucose quickly to prevent brain damage or further complications. Among the options, giving oral glucose gel might seem like an easy fix, but since the patient is unresponsive, oral administration isn't safe or effective. So the most appropriate action is to give IV 50 ml of 50% dextrose, also known as D50. This provides a rapid increase in blood glucose levels, which is critical in an emergency like this. It's important to understand that giving thiamine before glucose isn't the priority here, as thiamine is more relevant in cases of suspected deficiency, especially in alcoholics, but not in acute hypoglycemia. Giving glucagon can be an option if IV access isn't available, but in this scenario, IV D50 is the best immediate choice. Waiting for lab confirmation isn't appropriate because we already know the glucose is dangerously low, and delaying treatment could worsen the patient's condition. Overall, the key takeaway is that in unconscious hypoglycemic patients, rapid IV glucose administration is the most effective and immediate intervention. The correct answer here is E now. Let's break down why. When dealing with an unconscious patient with hypoglycemia, the fastest way to get glucose into their system is through the IV route. Typically, we use D50, but D10 or D25 can also be used if that's what's available. If IV access isn't possible, an intramuscular injection of glucagon becomes a good alternative because it can rapidly raise blood sugar levels. It's also important to remember that in patients with chronic alcohol use, we should give thiamine before administering glucose. This step helps prevent Wernicke's encephalopathy. However, we must never delay giving glucose just to administer thiamine, since hypoglycemia needs immediate correction. Overall, quick recognition and appropriate, rapid treatment are key in managing hypoglycemia effectively, especially in unconscious patients. Now, let's focus on the scenario presented here. After administering 50 ml of D50 intravenously, the patient initially regains consciousness, which is a good sign. However, interestingly, about 45 minutes later, they become hypoglycemic again. This highlights an important point about the management of hypoglycemia. It's not always a one-and-done intervention. The key question is, what's the best next step to prevent this recurrence? The options range from starting continuous dextrose infusion, giving another bolus, administering subcutaneous glucagon daily, initiating long-acting insulin, or deciding that no further treatment is necessary. It's crucial to understand that a single bolus of D50 may temporarily raise blood glucose, but it doesn't address the underlying cause or provide a sustained effect. In cases like this, where hypoglycemia recurs, a continuous approach is usually more appropriate to maintain stable blood sugars. This is where starting a continuous dextrose infusion, such as D10, becomes valuable. It ensures a steady glucose supply, reducing the risk of recurrent hypoglycemia. Giving another D50 bolus alone isn't sufficient because it offers only a short-lived correction. Administering subcutaneous glucagon daily isn't appropriate in this acute setting, especially when IV access and continuous infusion are options. Starting long-acting insulin would actually worsen the situation, as it lowers blood sugar over time. And obviously, if the patient is now stable, no further treatment isn't correct, because the hypoglycemia has recurred and further management is needed. So, in essence, the most prudent next step here is to begin a continuous dextrose infusion, until the patient can eat, providing a more stable and controlled correction to prevent further hypoglycemic episodes. The correct answer here is A now. Let me explain why. When we give a bolus, it causes a quick, transient rise in blood glucose levels. That means glucose spikes temporarily, which can be problematic if not managed properly. To stabilize those levels, we typically use a continuous IV dextrose infusion, like D10. This approach helps maintain a steady blood sugar level until the patient can safely resume eating normally. It's also important to note that repeat boluses can be risky. Each additional bolus increases the chance of rebound hyperglycemia, where blood sugar becomes too high, or hypokalemia, which is a dangerous drop in potassium levels. So overall, the strategy is to use continuous infusion rather than repeated boluses to keep things stable and avoid complications. This ties into our broader theme of careful glucose management in these patients. Let's look at this scenario. A patient who has taken glibenclamide and is now hypoglycemic despite receiving repeated dextrose boluses. This situation indicates that the hypoglycemia is not resolving with standard glucose therapy alone. The key here is to recognize that glibenclamide is a sulfonylurea, which stimulates insulin release and can cause persistent hypoglycemia. When conventional treatments fail, we need to consider specific antidotes or therapies that target the underlying cause. In this case, the best answer is giving high-dose glucocorticoids. These steroids can help increase gluconeogenesis and stabilize blood sugar levels by counteracting the excessive insulin effects caused by the drug. It's important to remember that in cases of sulfonylurea overdose, supportive measures are critical, but targeted treatments like glucocorticoids can make a significant difference. This highlights the importance of understanding the pharmacology behind the agents involved and tailoring our management accordingly. So, in summary, for a patient with persistent hypoglycemia after glibenclamide ingestion, high-dose glucocorticoids are indicated as the specific therapy. The correct answer here is A now. Let's break down why. Octreotide plays a crucial role because it suppresses insulin secretion, which can be very helpful in certain hypoglycemia cases. Specifically, it's effective when hypoglycemia is caused by sulfonylurea overdose and doesn't respond to just glucose therapy. This makes octreotide a targeted treatment option in those situations. Additionally, if someone has recently ingested a substance like charcoal, that can help absorb toxins and reduce further absorption. But when it comes to hypoglycemia caused by sulfonylureas that isn't improving with glucose alone, octreotide becomes a specific and effective therapy. It's important to remember this because it highlights how understanding the underlying cause guides us to the most effective treatment. So, in the context of managing complex hypoglycemia, knowing when to use octreotide can make a significant difference in patient outcomes. All right, let's take a look at this scenario. We have an unconscious patient presenting with pinpoint pupils and a suspected opioid overdose, and their capillary glucose is low. The key here is to determine the priority drug to administer in this situation. Pinpoint pupils are classic signs of opioid toxicity, and with the patient being unconscious, time is critical. The low glucose level suggests hypoglycemia, which can also cause altered mental status, but the presentation of pinpoint pupils points more toward opioid involvement. Given this, the most appropriate initial intervention would be to administer an opioid antagonist like naloxone. Specifically, using IV naloxone after confirming glucose levels addresses both issues effectively, correcting hypoglycemia if needed, and reversing opioid effects promptly. While other options like flumazenil or just giving dextrose alone are possible in different contexts, in this scenario, naloxone is the best choice because it directly counteracts opioid toxicity, which is the suspected cause here. So the best answer is a naloxone IV after glucose. This approach ensures we're addressing the primary cause of the unconsciousness while also managing the hypoglycemia. The correct answer here is A when managing suspected opioid overdose. The key is to act quickly and decisively. First, Give IV dextrose urgently to address any potential hypoglycemia if that's a concern, but more importantly, administer naloxone to reverse the opioid effect. Naloxone is a powerful opioid antagonist, and it can rapidly restore normal breathing and consciousness. It's crucial to remember that we should not withhold naloxone even if we suspect opioids are involved. The safety of the patient is the top priority, and naloxone has a very favorable safety profile. By promptly giving naloxone, we can prevent respiratory depression and save lives. This approach ties into the overall theme of emergency management, being prepared to act swiftly with the appropriate interventions. Always keep in mind that in cases of suspected opioid overdose, naloxone is your best first step, and don't delay administering it when indicated. Now, let's look at this question about a patient who has experienced prolonged severe hypoglycemia and remains comatose even after blood glucose levels have been normalized. The key point here is that, despite correcting the hypoglycemia, the patient's neurological status hasn't improved. This suggests that there may be additional brain injury or other underlying issues that need to be assessed. So, what is the most appropriate next step? The options include immediate lumbar puncture, repeating glucose testing, a brain CT scan, an electrolyte panel, or an EEG. Among these, the most critical is to evaluate whether there is ongoing brain injury or other neurological issues that could be causing the persistent coma. A brain CT scan is particularly useful here because it allows us to assess for hypoglycemic brain injury, such as cerebral edema or structural damage, which can sometimes develop or become apparent even after glucose normalization. This step helps us understand whether the brain has sustained injury that might influence further management or prognosis. Other options like lumbar puncture or electrolyte panels might be relevant in different contexts, but in this scenario, the priority is to visualize the brain directly. An EEG could be useful if we're considering non-convulsive seizures, but the immediate concern is structural injury, making the brain CT the most appropriate next diagnostic test. Connecting this back to our overall theme, the importance of timely and appropriate diagnostics in hypoglycemic emergencies, this step ensures we're not missing secondary brain injury that can impact recovery. So, in summary, the best next step here is to proceed with a brain CT to assess for hypoglycemic brain injury. The correct answer here is C. After prolonged severe hypoglycemia, one of the main concerns is hypoglycemic brain injury. It's important to evaluate this with imaging studies like CT or MRI of the brain to look for structural damage. While EEG can sometimes be helpful, I would prioritize imaging first to identify any edema or ischemia that might have resulted from the hypoglycemic episode. This approach helps us get a clearer picture of the brain's condition and guides further management. Remember, the key is to assess for potential brain injury after severe hypoglycemia to ensure appropriate treatment and prognosis. Let's talk about the initial steps in managing severe hypoglycemia. The first priority is to rapidly restore the patient's glucose levels. If an IV access is available, administer D50 IV. If not, IM glucagon is the go-to, and we shouldn't delay treatment. It's important to give thiamine if the patient is malnourished or alcoholic, but only after we've addressed the immediate glucose deficit. To prevent recurrence, we should continue with a D10 infusion until the patient can safely take oral intake. When dealing with sulfonylurea overdose, octreotide can be very helpful, and in recent ingestions, activated charcoal might be considered. Also, keep in mind that some cases require prolonged monitoring to ensure stability and detect any delayed effects. Now, let's consider potential complications. Severe hypoglycemia can lead to seizures or even permanent neurologic injury, so we need to be vigilant. Imaging or EEG might be indicated depending on the clinical scenario. The key takeaway here is prompt recognition and treatment are crucial to prevent lasting damage. Thank you so much for your attention today. I really appreciate your time and engagement throughout this presentation. I hope you found the information useful and inspiring. Remember, the The key takeaways are about understanding the core concepts we discussed and seeing how they connect to the bigger picture. It's been great sharing these ideas with you, and I look forward to seeing how you apply them in your work. Once again, thank you for being here and for your interest.